Sir is Mr. Virinder Kumar Sharma. He's the DC. And friends, just like we have MBBS, MS, DM, DCH, and MCH, Sir is an engineer, a PCS officer, and an IAS. He is a Bachelor of Engineering from the Punjab Engineering College, a very reputed institute. After that, he cleared his civil services exam. And then he has also been in the district food and supplies office. So this is a multifaceted and very, very qualified officer you have in the administration. And he is running a city like Ludhiana, which is basically an industrial town, but full of other educated professionals also. And the landmark of his deputy commissionership has been steering us through COVID. His calm demeanor, his repeated videos were a big moral support for us. And they did a lot of work. The district administration, the civil surgeon office, and also the deputy commissioner. They did a commendable job. Ludhiana did not face such a big crisis as some of the big cities. Sir, please, we welcome you to the dais to give us a few words.
Fogsi. Dr. Shanta Kumari, Dr. S.P. Singh, who is the civil surgeon of this district, Mrs. Mamta Ashu, who is the councillor of this area, other office bearers of Fogsi, and all the doctors present here. Very good afternoon to all of you. Sharing of knowledge, because it's a 3-day interaction which you are having here, and I am sure that after this experience sharing, your experience and your skills will be much. When 3 doctors came to invite me, because there are many invitations, the day was very, very busy suddenly. So with that, I'll thank you. About 15, 16 years back, during the first pregnancy, my wife had some complications, and complications of such level that it could not be solved. It was a very, very difficult decision. After your marriage, you are so young. Our parents also were a little hesitant. Why do you want to go to such faraway places? So many doctors here. But somehow we mustered courage and went to Bombay. And she was so caring and so guiding. Dr. Sadhana K. Desai, through you, I thank her because of that. I am having 2 beautiful daughters today. Because it being my personal case, I'll insist her to visit my home out of her busy schedule. I could see number of women waiting outside her waiting room. She was a very, very busy doctor. But despite that, she'll come to my home and guided us. And because of her also, a lot of happiness at my place. So your important role, I know what kind of happiness you fill into the lives of so many people. I remember the day when it came positive. Every day we will wait so eagerly, because she said that after 15 days you will come for first scan, and that small blink on the monitor saying that yes, heartbeat is okay. I was so elated. And the journey of another 7.5 months, that was on 1.5 months, said to Bombay doctor, Dr. Sadhana K. Desai. And I salute her patience also. And finally, my elder daughter, she was born with the C-section. And the second one, there was not much difficulty. But out of that episode, I have a lot of respect for you, especially gynecologists, because your role is very, very important to complete the family. So I am here just to say a big thank you to all of you, because a lot of you will be playing the role of Dr. Sadhana Desai or Usha Madan into the lives of others as they played into my life. Thank you very much, and keep doing good work. My best wishes.
Thank you, sir. Please stay.
Had an article coming yesterday saying that microplastics have been found in the bodies of human. Yesterday saying that microplastics have been found in the bodies of human beings, and that something is where we can fight. Ma'am, applaud to you that you brought this up, because you saying it is going to create consciousness in the minds of those 38,000 strong Foxy body.
Thank you, sure, ma'am.
ये भी दे दो, गेस्ट ऑफ ऑनर भी दे दो।
I would also, on what topic we have, Surakshith Dharti, Surakshith Nari. One of the main backbone of this Surakshith Dharti is Ma'am Mamta. She's always helped us whenever we need, and she's always helping the grassroots level workers, especially the.
सबके हो गए प्लाक हो गए माधुरी पटेल, सबके हो गए प्लाक हो गए माधुरी पटेल का प्लाक।
Yeah, vote of thanks, madam. Vote of thanks. मैडम का प्लाक है, मैडम का प्लाक है, बड़ा बड़ी प्लाक है। ऑडिशन नहीं होता, उनका ऑडिशन नहीं होता।
AFOGD का है ना उनका, नहीं उसके बाद है इंटरनल एप्लीकेशन पे
It is an honor and privilege for me to propose a vote of thanks on this occasion. On behalf of my whole LOS team, I give a hearty thank you to our president, Dr. Shanta Kumari, who has for us. She was the one who worked hard that Ludhiana gets this. And I also thank our elegant secretary, Journalist Madhuri Patel, and our enthusiastic Vice President, Dr. Archana Verma, for being there as a pillar of support at all times. I also thank as a pillar of support at all times. I also thank Soeb, Dr. Basab Mukherjee, our Vice President, young hands strength in these times. And Dr. Harpreet Negi for gracing this occasion. For her kind presence. I also want to thank our energetic members of the Ludhiana Obs and Gynae team for being our backbone and our pillar of support at all times. I thank you one and all. Thank you.
Yeah. Myself, Dr. Venus Pansal. I would say everyone, our whole team has already thanked everyone. I just want to, before we start or not, but yes, we have come out of our comfort zone and have tried to thank you everyone for taking out time. And now, Sanchita, you can give the placards and we can start with our Dhira walk, which will end with balloons released in the air. Thank you so much. On the way, there is a Dhira wall where the signatures will be done. Dhira is violence against women, and that is a project of Shanta ma'am, which has been put beautifully.
फोटो ये आना चाहिए। डॉक्टर गीतांजलि, डॉक्टर गीतांजलि, डॉक्टर वीनस, डॉक्टर वीनस, वो चेयरपर्सन। Good afternoon, everyone. Nice to have the audience back. So it's high time we start with the after lunch session. And as a first lecture in the after lunch session, we have none other than Dr. Jaideep Tank with us, speaking on gestational diabetes, providing optimum care. So as chairpersons, I invite Dr. MC Patel, Dr. Gitanjali, and Dr. Venus. We all of us, we know Dr. Jaideep Tank. Dr. Jaideep Tank is a Secretary General, Fogsi, 2018 and 2021, and he is our incoming presidential candidate. Dr. MC Patel, each one of us knows, and Dr. Gitanjali, Dr. Venus. Dr. MC Patel is a consultant, obstetrician, gynecologist, and medical legal advisor. He has been the Vice President, Fogsi, 2018, and he's the chairperson, Ethics and Medical Legal Committee of Fogsi from 2011 to 2013. He was the president of Ahmedabad Obstetric Gynae Society 2010 and 11, and I can go on and on and on speaking about him. But it's high time. Dr. Jaideep Tank, sir. Dr. Jaideep Tank, sir, welcome. Over to you.
Do we have a pointer? Can you switch on that mic? Chairperson's mic?
So, good afternoon, everybody. Dr. Jaideep Tak will just been was introduced, and he's going to talk about gestational diabetes, providing optimum care. So we know gestational diabetes is a very common high risk factor as far as any pregnancy is concerned. And when we encounter this type of cases, we should be very alert, because with complication related to GDM, it becomes very difficult for obstetrician to deal with the case accordingly. And IUFD is known entity in uncontrolled GDM. So as far as counseling is to the patient is concerned, when she's diagnosed as a case of GDM, it is also very much important and to take utmost care. And how we should do all this care. May I please request Dr. Jaideep Tak to deal with the subject. Yes, Jaideep.
Thank you very much, sir, for that very kind introduction. Let me say it is such a pleasure and privilege to be here at what used to be called the North Zone Yuva Fogsi. And I don't know how many people realize this, but this is the first Yuva Fogsi conference after the Yuva Fogsi has been renamed. So I think Ludhiana Society has a unique privilege of holding this conference, which is the first of its kind in the history of Fogsi. Thank you very much to the wonderful, wonderful organizing team of the Ludhiana Society, Vidhu, Dr. Gitanjali, Venus, Dr. Manu, Vani, Dr. Kavita Madam, Dr. Ashima, Dr. Suman, Dr. Ginny, Dr. Poonam, Bhavna, Dr. Zini, and Dr. Barinder, the respected seniors, patrons, and advisors of the Ludhiana Society, and of course, the office bearers of Fogsi, led by our dynamic president, Dr. Shanta Kumari, the Secretary General, Dr. Madhuri Patel, and of course, our absolutely wonderful vice presidents, Dr. Archana Verma, who has the privilege of being in charge of this conference, and my dear friend Basav, who I believe is speaking after me. Thank you to the chairpersons, MC Patel sir, Dr. Gitanjali and Venus. And I must say it's a special pleasure to be speaking alongside Preeti in the same session. And I always tell Preeti that, you know, she does so much work that I'm not the Secretary General anymore, but when I was the Secretary General, I always felt I should have one staff in the office exclusively for Preeti's use because she always used to do so much work. And it's such a pleasure to meet so many old friends. Well, in the next 13 minutes and 21 seconds that are left to me, I will try to encapsulate what the optimum management of diabetes in pregnancy is as far as a very clinical perspective goes. I'm not really going to talk about the theory or the etiologies and so on and so forth. I will just try to focus on what we should be doing when you're sitting in the clinic and you have a patient in front of you where you think there may or may not be GDM. And let me begin with this very important slide. This is a slide of 2 screenshots taken of Medline searches. You'll see one of them is done for GDM and the other one is done for diabetes and pregnancy. And what is very telling about these slides is that if you look at that graph, which I have blown up on the side, you'll see that depending on which terminology you choose, the number of articles that are published year on year on the topic that you're searching for changes. And for me, that has always been something a little worrisome. Because if there is such a large change in the articles that you're going to reference, depending on the terminology that you're going to use, then how can we ever hope to achieve a uniform consensus? And that is why, particularly in tricky situations like diabetes, we need to also look at comprehensive guidelines, because a cursory Medline search may not really elicit all the information that you would like. And these are the guidelines that I have used along with the Medline search in preparing this presentation. We know that there is a certain maternal and fetal morbidity which is associated with GDM, and all these morbidities have been outlined very nicely in this article from Boshe-Hoth's committee from FIGO. Essentially, it seems that when there is a hyperglycemia in pregnancy, has an effect on the fetus. Either there is a formation of macrosomia, which leads to an increased tissue consumption, or a reduction in lung surfactant synthesis, and both these taken together seem to cause adverse effects in the fetus. It therefore is crucial to identify who is the woman who has GDM in the first place. And if you look at the guidelines which have been adopted by the NHM, the Government of India, alongside FIGO, you will see that universal testing of GDM is recommended. Now, this is fairly important from the public health perspective, because when you talk about universal screening, you're talking about a massive resource commitment to public health. So universal screening, ideally with 75 grams of glucose in 300 ml of water, and 2 hours later, do a plasma glucose value. There are some votaries who seem to think it's just better to do a random sugar so that the patient doesn't have to wait in the OPD, but this is what is recommended. If it is positive, then you initiate therapy, and if it is negative, you should ideally repeat a test at 24 to 28 weeks. What is gaining extreme importance, more than the pharmacological treatment of GDM in pregnancy, is what is now called MNT, or medical nutrition therapy, which involves healthy eating in a pregnant woman after calculating her daily caloric requirement on the basis of height, weight, and level of activity. So these are the principles of an MNT, and what it aims to do is provide optimal nutrition without compromising on the glycemic level. So if you have a patient where you need to start MNT, how do you start it? You take the anthropometry measurements. Based on the BMI, categorize the women, calculate the ideal body weight, and then calculate the calories that are required. And once you have done that, you say second trimester plus 150, third trimester plus 350, and so on and so forth. And then, of course, you need to counsel them with the right distribution. To my mind, it has always been better that when you're prescribing such a complicated nutrition therapy, it's a good idea to have a dietitian or have the patient counseled by the appropriate person. So these are the way the calories should be distributed. And of course, we have now realized that carbohydrate counting is in fact very important in GDM because food which change into blood glucose, carbohydrates constitute the bulk of that. So when you look at the management of pregnant women with GDM, you first prescribe them medical nutrition therapy with physical exercise, and then do a 2-hour PPBS after 2 weeks. If it's less than 120, then that means you can continue with MNT, that's the nutrition therapy and physical exercise, and then keep on monitoring 2-hour PPBS at least every month. Maybe up to 28 weeks, you could do it once in 2 weeks, and after 28 weeks, perhaps even more often once a week. If it is more than 120 after 2 weeks of MNT, you then need to put the patient on some pharmacological therapy. Oral hypoglycemic agents were initially looked at very skeptically or with a lot of cynicism, but there is quite clearly a changing trend in the acceptability of OHA in hyperglycemia in pregnancy. In fact, OHAs are supposed to be non-invasive, cost-effective, and patient-friendly, which ultimately leads to better compliance. The drug of choice as an oral hypoglycemic agent in pregnancy seems to be metformin, which acts in various ways to reduce the glucose production, etc. You can give metformin after 20 weeks of gestation, although if you extrapolate the findings and the use of metformin in patients with PCOS or hyperinsulinemia, it clearly has been used even before 20 weeks of gestation. You start with 500 milligram BD and you can go up to 2 grams per day. There are side effects, but most of the time these side effects have a time limit. Over a period of time, the body gets used to metformin and the patient starts tolerating it very well. In fact, you can see here this study which says that when you give metformin in the first trimester, there is in fact a statistically significant protective effect for fetal malformations, and there have really not been any significant abnormalities of growth, etc., shown with metformin in several trials. If you look at this MIG trial, you will also see that there's no significant difference whether you use metformin or insulin. And I think that's a very, very important piece of evidence because it means that you can manage patients who can possibly be managed with oral hypoglycemic agents instead of putting them on something which is relatively more morbid and has several more side effects like insulin. Having said that, the modern insulins that are available are considerably better than what was available earlier. Having established that metformin, first medical nutrition therapy, followed by metformin, you would then need to start insulin if your fasting sugars are more than 120 or the 2-hour PPBS is more than 199, or when sugars are not controlled and the targets which you want to achieve are not met. So this is how you will start insulin. You can see there 2-hour PPBS of more than 120, start human insulin premix 30-70, 30 minutes before breakfast, and then titrate the dose of insulin as per the sugar. If at some point in time later on, the medical nutrition therapy does not seem to work, you again need to titrate your insulin dose to the level of the sugar. So these are the recommendations for glycemic target. And to be perfectly honest, these recommendations seem to keep on getting more and more stringent every year. There was a time when we used to be happy with a sugar of something like 110. But if you talk to the modern diabetologists, they are now saying that you should have sugar levels somewhere in the vicinity of 90. And I'm always a little skeptical about that because quite clearly, I'm not sure whether this data on the need for having such a tight control, particularly on insulin, is something which will actually be beneficial or will cause certain episodes of hypoglycemia in the women. When should you deliver these patients? In practice, we generally tend to deliver them at 37 weeks, either by induction of labor or by C-section. And remember that once the patient delivers, you need to look after both the baby and the mother quite differently than you were used to doing in a normal pregnancy. For neonatal care, you need to monitor the baby's glucose because these children seem to have a propensity for developing hypoglycemia and sometimes even have hypoglycemic convulsions, the consequences of which are really quite uncertain and unknown. In terms of postnatal care, women who are taking insulin, the insulin should stop immediately because blood sugar drops precipitously once the baby has been delivered. It is better that women who are on insulin stop taking the insulin completely, and then you can either start them on oral hypoglycemic agents or on insulin, depending on the blood sugars. At the end, I'm not hopingly encroaching on Preeti's presentation, but a follow-up is extremely important, and Preeti will be speaking about that. So Fogsi had done this WDF project, which seemed to be quite effective. What we did was partnered in the public sector and tried to look at both the incidence and the management of diabetes. So let me end with this slide. And if you recognize that, that's Lisa Simpson from the cartoon The Simpsons, very popular TV series. And over there, Lisa says, salt is just angry sugar. And in fact, if you really think about it, they both have detrimental effects on health. We have, of course, come a long way since the first use of insulin was described. And as this quote says, this is a classic example, hyperglycemia in pregnancy, that abundance, like want, ruins many. Let me end with a request to all of you to please support me as I stand for the presidency of Fogsi. You are aware that the election is going on. The election will end on the 30th of March at 5 p.m. It's very, very easy to cast your vote. You must have received a link, and if you open your SMS app and search for e-polls, you will be able to see your link. And if you open your email app, you will see that there's an email from eBallot. If you have not cast your vote, please do so. If you have not received the link, and I say this with some relief because I'm not the Secretary General anymore, you have the present Secretary General sitting here. You can please reach out to her, and I'm sure Dr. Madhuri Patel will help you, have the link sent to you, and then you will be able to vote. It is, of course, extremely important to vote in any kind of democracy. And I must say that in this particular instance, as important as it is to vote, it is also very important that you vote for me. Thank you very much.
Clear talk. We are in Punjab, which is the diabetic capital of the world. And yes, we have so many young patients in the 30 to 40 age group having diabetes. And I always tell them, your mothers were not taken better care. We will be better obstetrician and take good care of you, that the next generation does not get imprinted like this.
Sure.
So thank you, sir, for your,
Thank
and
you.
I wish you all the best for your
Thank you
elections.
very much, Dr.
Now,
I'm sorry, chairpersons, but I will have to leave in another 5 minutes because I have a flight to catch. So if you'll excuse me, I'll take your
Sir.
leave. Thank you.
now I would like to invite Dr. Preeti Kumar, the young dynamic chairperson of Safe Mother.
Dr. Gitanjali, there's a
he also-
change.
Okay, sorry, I'm sorry.
Thanks, Dr. Jaideep, sir. It's always a pleasure listening to you. A very crisp and a clear lecture. So next coming to us is Dr. Basav Mukherjee speaking on gestational trophoblastic diseases, recent guidelines. And we are changing the schedule a bit because they have flights to catch. So about Dr. Basav Mukherjee, he needs no introduction. He's been the Vice President of Fogsi 2021-22. He has been the Vice President Bengal OB-GYN Society. He's been the member ICOG Governing Council, and the list goes on and on. I think it's time to start the lecture. Dr. Basav, please.
Thank you very much. Again, I echo Jaideep's message that we thank Ludhiana OB-GYN Society and the team led by Dr. Vidhu for holding this wonderful conference here. Over the next 10 to 12 minutes, maybe 13 minutes, we'll take you through gestational trophoblastic disease, recent guidelines, a topic which you do not hear every day because the normal statistics say that one gynecologist will see a disease of molar pregnancy or GTD not more than one in 2 to 3 years. And some people with not a very big clinical practice may not see it, maybe 1 in 5 to 10 years. So there's a less chance that you'll be coming upon a case like this. But it is important to understand in which situations will you be testing, in which situations will you be suspecting, and in which situations how to treat and how to manage some basic outlines. So the guidelines from which we have adopted the next few slides is from the green top in guidelines of the RCOG, which was published in September 2020, some ACOG guidelines in 2021, the SOGC, Society of Obstetrics and Gynecologists of Canada, again published around 2020-2021, and the FIGO Cancer Report 2021 of Diagnosis and Management of Gestational Trophoblastic Disease 2021 update. So what we're going to share here is fairly recent, and this is something to go by. So just going through you the spectrum, gestational trophoblastic disease and gestational trophoblastic neoplasia. That is the two terminologies which we use. So we talk about neoplasia either when it is a malignancy already existing, when it's an invasive mole choriocarcinoma, placental site trophoblastic tumor, or an epithelioid trophoblastic tumor, or also we talk about a malignant potential when a beta HCG does not come down and continues to be high and plateauing after a molar pregnancy or after ectopic managed conservatively, etc. So the awareness of the clinicians should be that clinicians must be aware about the signs and symptoms of a molar pregnancy. Often it is easy nowadays when we have dating scans and all women are having scans around 7-8 weeks to see viability and for dating. But at the same time, there are many people who are not having early scans, and sometimes you may have a person who's presenting to you later in pregnancy and there are some issues of irregular vaginal bleeding, supporting ultrasound evidence, positive pregnancy test where the suspicion obviously has to come in. The less common presentations could be hyperemesis, which would be accompanying the thing, excessive uterine enlargement, which we have heard from our undergraduate and postgraduate days. One of the differential diagnosis in a excessive large uterus besides multiple pregnancy and wrong dates is a molar pregnancy. Then there's hyperthyroidism, early onset preeclampsia, and abdominal distension, not due to the pregnancy, but to large theca lutein cysts. Around 50% of the gestational trophoblastic neoplasia that we know occurs after a molar pregnancy, but there's another 50% which we need to be aware happens after a non-molar pregnancy. So it could be an ectopic, it could be an abortion, it could be a normal pregnancy after which a woman can present with irregular bleeding. And if we do not do a serum beta HCG levels, we may miss gestational trophoblastic neoplasia. Some tip points about evacuation of a molar pregnancy. It's not new, but something which we know, but this recent guidelines are stressing that an ultrasound guidance would be the most ideal if you can do it under ultrasound guidance to ensure completion, minimize risks, and the risk of perforation to be more certain. For suction evacuation is a choice, not medical methods of abortion. Normally you'd be giving misoprostol or mifepristone, but not in a case of molar pregnancy. Suction evacuation remains a choice, and there is a tip not to avoid sounding, because there's a very high chance of perforating the uterus. And make sure, like what we talk in dilatation for everybody, the cervix is only 2 to 3 centimeters. It doesn't reach, it's not till the fundus. So you just have to dilate just a little bit, and you have to be very careful because of the high chance of perforation here. IV oxytocin drip, there has been debates among various groups about giving uterotoxin and methergin and other uterotonics. The reason for the debate is that there is a worry that there may be embolization of the trophoblastic material into the venous circulation if you really force contractions of the uterus. But most of the non-European guidelines say that it's not true. You can start IV oxytocin in a drip during the procedure and continue it after. So blood transfusion facilities need to be there, especially if it's a more than 14 to 16 week size uterus, when you're anticipating heavy bleeding and she presents with a pre-operative low hemoglobin. Uterotonics, as I already mentioned, the hemostasis versus embolization risk is something which you balance, but now the tilt is towards hemostasis, so you will use it anyway. If it's Rh negative, there was a debate once upon a time that if it's a complete mole, you have less vascularity, less exposure of the D antigen, and you may not need anti-D. Now that's no longer there anymore. So if she's an Rh negative, you have to give anti-D. The dose is not clearly mentioned. Usually what you get hold of, it may be 50, 100 or 300, what you have available with you. A hysterectomy option is always there if the age is more than 40. Post miscarriage, when are the times when you will suspect GTD? There is a recommendation which has come from these guidelines that the urine pregnancy test may be recommended after 3 weeks for any woman who undergoes a miscarriage. And now this is something like, there's so many abortions that we conduct, medical, surgical. There is a recommendation, a UPT after 3 weeks. And if this is high, if this is persistent high, there is a case for doing serial serum HCG levels and to continue and see whether they are plateauing or falling. If the symptoms of pregnancy persist 4 to 6 weeks after a TOP, or if there's persistent or irregular bleeding more than 8 weeks after a pregnancy event, all of those will warrant HCG determination. So besides the different other differentials like retained products of conception, endometritis that we may think of, there is also a thought that it may be a gestational trophoblastic neoplasia, and so you need that also would be one of the differentials we need to think. Post-miscarriage, about routine histopathology examination. Now, that's also was a thought that if there are no fetal parts seen on ultrasonography, there is a case for doing HPE in every surgical evacuation that you do. In medical evaluation, obviously, it will not be possible, but there is, or if the material which is taken out at surgery looks suspicious, then there is a case for doing histopathology examination. Rarely, if the people may present with already metastasis happening in the lungs and CNS with localizing signs. So now comes a very important question, which we have had essays on when we were writing long answers in our exams, the post-molar pregnancy follow-up. So what does the recent guidelines say? What frequency do we need to check our beta HCGs, and when do we stop? So the beta HCG, what is suggested by the SOGC is weekly HCG levels to start 2 weeks post-procedure till levels are undetectable for 3 consecutive weeks. So weekly after 2 weeks till undetectable for 3 weeks. If it's a complete molar pregnancy, HCG, and HCG is normal in 8 weeks, then you can follow it up for 6 months and then stop doing monthly checks. If the HCG is not normal in 8 weeks, it takes longer to come to undetectable levels, then you have to do it till 6 months from the normal HCG value. So that's come out from the RCOG requirements. And partial molar pregnancy, 2 normal HCG samples at least 4 weeks apart is fine. And when can the woman plan for her next pregnancy, which is the obvious question which she will ask you. If she can conceive after the follow-up is complete. What is follow-up? We've already mentioned in the previous slide. After 6 months, if it's for a mole. After 1 year, if she needs chemotherapy for any reason. Previous non-GTNs There was a question then, when a woman who had a molar pregnancy, in her next pregnancy, do you need to do post-delivery HCGs or do you need to do the placental biopsies? And now that is not required in the recent guidelines. If she has a non-GTN case, when she had a molar pregnancy or a partial mole, which was not a GTN, and then in the next pregnancy when she has it, you do not need to do post-delivery HCG, but you need to monitor her closely because the chance of recurrence is high. It's nearly 10 times. So normal molar incidence is 1 in 1,000, but after one mole, it's 1 in 100. So optimal treatment for GTN treatment is based on the FIGO 2000 scoring system for GTN, and I'll just run to the scoring system. This is what it is. So there is 0, 1, 2, 3, and it's all available on the net. So age, antecedent pregnancy, interval between the index pregnancy to the treatment, pre-treatment serum HCG levels, size of the metastasis, number of metastasis, largest tumor size, and previous failed chemotherapy. So that's for the numbering, and the staging also is there, 1, 2, 3, and 4. And so then the treatment therapy, which we are aware of, the chemotherapy, single agent or multiple agent, will depend on the scoring system. And whether you need adjuvant therapy or primary surgery may depend. If it's a placental site tumor, then it possibly may be the first choice. We have heard about EMACO from our postgraduate days, and things haven't changed since then. It's given till 6 weeks after the HCG levels have remained to normal, and then imaging for the CT chest, abdominal, brain. So after the GTN treatment, it's nearly 100% cure. Further pregnancy is seen in 80% cases. There is an increased chance of premature menopause because of the chemotherapy. There's increased GTD risk, I've already mentioned. About contraception, just one word. Yes, all contraception can be used after the levels have come to normal, but when they're still high, it's intrauterine devices are avoided. So in the special scenarios for recurrent GTD, it needs to have genetic counseling. Molar pregnancy coexisting with a normal fetus needs to be seen by a specialist, and prophylactic chemo after a diagnosis before scoring her is something done in very limited cases. So the takeaway from this talk, clinicians need to be aware of the clinical situations where GTD or GTN may be suspected. Clinicians should manage molar pregnancy cases appropriately with necessary monitoring and follow-up, and referral to specialized centers or specialists more familiar with the disease as and when needed, because a lot of people see it very rarely. Thank you very much. Thank you.
Thank you, Dr. Basa, for a very elaborate illustration. But anyway, we are not seeing many patients as far as this is concerned. Thank you so much.
Thank you, Dr. Sushma. Thank you.
Thank you, Dr. Basa, for the crisp and clear lecture. Sorry to my chairpersons, there was some confusion with the lectures. It was interchanged because Dr. Basa needed to leave. So I would be failing in my duty if I do not welcome Dr. Sushma Chawla. So ma'am is the chairperson in this session. Ma'am is a dynamic and a senior gynecologist, obstetrician, laparoscopist, hysteroscopist, colposcopist, and an IVF expert. She's been an honorary professor ICMCH. She runs Chawla Nursing Home and Maternity Hospital in Jalandhar. She's been a joint secretary IMA WDW North Zone, founder, chapter secretary of IMS, president Narchi Jalandhar branch, president Rotary Club Jalandhar West, president IMA Jalandhar. She's been awarded Narchi Lifetime Achievement Award, Best IMA President Award, the Gold Medal for Best Postgraduate. She's been the Best Girl Guide, NCC Cadet, and the Best Athlete in School. Welcome, ma'am. Next, we have ma'am Dr. Surjit Kaur. She is the Director of Parivar IVF Center and President Jalandhar OB-GYN Society. She's been the Vice President ISAR Punjab Chapter. She's working at Parivar IVF Center, a unit of Holy Family Hospital in Jalandhar. She has a gynae and obstetrics experience of 45 years and an IVF experience of 20 years. She's a laparoscopist, hysteroscopist, and colposcopist, and has an IVF center. Welcome, ma'am, Dr. Vaneet Kaur. Ma'am is a postgraduate diploma in medical law and ethics. She's a senior consultant and head OBGY Sapling Hospital, and ex-senior consultant and head OBGY at Fortis Hospital and SPS Hospital, and ex-professor and head CMC Ludhiana. She's a fellow of Indian College of Obstetrics and Gynecologists, past president of LOS. And I would be failing if I do not welcome Dr. MC Patel again. Each of us knows Dr. MC Patel. Sir, welcome. And next, we have Dr. Preeti Kumar. I would welcome Dr. Guinea to speak about Dr. Preeti.
I will just take a minute to remember that it was Dr. Preeti Kumar, the chairperson of Safe Motherhood Committee, who first invited me and Dr. Vidhu to Lucknow, and there the love and the zeal for studying and the passion for organizing the conference when Dr. Vidhu began. Dr. Preeti is known to everybody. She is also called the mother of the Safe Motherhood Committee. There are so many projects, Jeevan Dhara 1, 2, and now Jeevan Dhara 3. Nepal has called her to conduct the Jeevan Dhara there, the one which she has conducted in UP, training thousands of healthcare workers, hundreds of doctors. She has donated NSG and UPT to our society and also organized the workshop of Safe Mother, under the Safe Mother, the obstetric workshop. Welcome, Dr. Preeti. Always welcome to Ludhiana and keep working with the same endeavor and zeal.
And very appropriately title selected for Dr. Preeti Kumar, GDM today, NCD tomorrow. And we all know that any patient of GDM, they are much more prone to be a patient of diabetes type 2 in future. So Preeti is very right person to deal with the subject because she has very pioneering work as far as GDM is concerned. So now stage is yours, Preeti.
Thank you so much. Thank you, Ludhiana Obs and Gynae Society. Thank you so much for the warmth, love and affection that we are getting for last 3 days. With special permission of the chairpersons, thank you so much for chairing this session, and heartfelt gratitude to our Fogsi leaders, Dr. Shanta Kumari Madam, our Secretary General Fogsi, Dr. Madhuri Patel ji, the Vice Presidents of Fogsi, and all the Fogsi office bearers for giving me the opportunity to work for the nation, to work for the women's health. So I'll be speaking on a very important topic. Dr. Jaideep has touched upon some of the important aspects of GDM, but I would like to focus on some of the issues that our country is facing right now as far as the GDM is concerned. So my topic is GDM today and NCD tomorrow. And before I start my presentation, again, I would like to thank Ludhiana OB-GYN Society, especially Vidhu and Guinea, and of course, Geetanjali, Venus, and the entire team for inviting me here. I have 15 minutes. A little bit attention is needed from the participants today or delegates today. GDM, it is very important to understand that what Dr. Jaideep has mentioned, we now call it as hypermarket, whether this is a diabetic patient who is getting pregnant or it is a GDM per se. Most of the cases of GDM are detected in the second trimester after 20 weeks when there is an insulin resistance by placental hormones, and GDM is defined as glucose intolerance of variable degree with onset of first recognition during pregnancy. Of course, single-step test is the need of our in our country, but many of our OBGYNs, they follow either IAAD-PSG criteria or WHO criteria or maybe ACOG criteria. But whatever criteria you're using, please detect GDM as early as possible in the pregnancy. We know that hyperglycemia in pregnancy is a major global health challenge, and you should not forget that India is one of the leading countries in diabetes mellitus. And we as an OBGYN have a great responsibility of reducing this burden of diabetes in our country. Now, as you can see, India is one of the top 10 countries of diabetic load in the world. And let us see this case, what happens usually in our practice. This is a 20-year-old female. First delivery was 3.9 kg baby 10 years back. 11 years later, second pregnancy with BMI of 30, 12 weeks of gestation, a single step test shows 248 milligram percent and HbA1c of 8.8. So where did we miss? She was not tested after the first pregnancy. She was not tested before the pregnancy, or she was not done the preconception counseling, and therefore the early detection of diabetes occurred in the first trimester, where she has a very, very high chance of developing a diabetic baby. So window of opportunity, definitely pre-pregnancy offers a window of opportunity and provide a maternal care services, and it reduces the traditional maternal and perinatal mortality and morbidity, and thus intergenerational transmission. It is very important for us as an OBGYN to understand that we are basically dealing with two lives. One is the mother and the second one is baby. And it is very important to understand as early as the fetus detects sugar in the mother, that baby is more likely to develop type 2 diabetes mellitus and many more complications in the pregnancy. So that is why it is said that the baby should not come to know that the mother is diabetic. As soon as the baby comes to know that the mother is diabetic, the baby is bound to have as many complications as possible post-pregnancy. Now, when does the malady start? It starts in pregnancy, and it is very important to understand that even the low birth weight babies also have high chances of non-communicable disease rather than also macrosomic babies or babies with a high diabetes. Now, these are the two hypotheses that we talk about. One is the Barker's hypothesis, and the other one is Pedersen's hypothesis. In Barker's hypothesis, it is all the undernutrition, maternal undernutrition that leads to fetal growth. Babies are more prone for non-communicable diseases. Now, Pedersen hypothesis is that whenever mother has a high sugar level, then it crosses the placenta and makes the baby more macrosomic, a large size baby. So malnutrition is also linked with non-communicable disease. FIGO has taken up that as a pony trial. This is Pregnancy, Obesity and Nutrition Initiative, that many of the maternal deaths in the babies are affected by malnutrition in the mother. We all know about the complications in the mother and the fetus. I'm not going into the detail, but it is very, very important to understand that GDM today is the NCD tomorrow. It is very important for us, again, to highlight that what Dr. Jaideep was talking about, we can give metformin to these patients after 20 weeks of gestation. But again, if you find that the sugar levels are normal and the baby is having a high complications like macrosomia or polyhydramnios, think twice, even if the sugars are normal, think twice whether the sugar levels in the mother are normal. Why I'm saying that even a single spike of high sugar in the mother stays there in the amniotic fluid for more. So that fetus keeps on engulfing that high sugar fluid, and it continuously stimulates the pancreas. So a single spike of sugar in the mother may be deleterious for the baby. So it is very important. Sometimes you get a fasting and postprandial normal, but many of the times the mother may be having obstetrical complications. It's a right time to switch over to insulin rather than giving the oral hypoglycemic drugs. So now this is a long-term maternal adverse effects, what have been noted in GDM, definitely type 2 diabetes mellitus, metabolic syndrome, cardiovascular disease, renal disease, ophthalmic disease, and some of the malignancies. Mothers who develop diabetes, again, there are two schools of thoughts, whether the controlled GDM also develop type 2 diabetes mellitus. The answer is yes. If a mother has a controlled pregnancy in the antepartum or in the partum period, again, these mothers have a very, very high chance of developing 10 times high risk of developing diabetes mellitus. And this is the biggest challenge in our country, that we are not doing the postpartum follow-up of these mothers. So it is not only the mother, but also the baby is at a higher risk of developing type 2 diabetes mellitus. Again, the cardiovascular risk, if the mother is obese, then there are more chances of type 2 diabetes mellitus and cardiovascular risk. And American Heart Association has included history of GDM in their classification of cardiovascular risk factors in women. Renal diseases have also been associated with GDM patients, and they have been seen that after maybe 10 or 15 years of delivery, they may have high chances of renal diseases in these mothers. So you have to have a track of renal functions also in these patients. Ophthalmic disease may be a consequence of GDM, hyperglycemia, or it may be associated hypertension in these patients that can have many of the ophthalmic complications. Malignancies like ovarian, endometrial, and breast cancers have also been associated with GDM, so you have to have a track of all these malignancies. We talk about the mothers, but we forget about the babies. The fact is, if a mother is diabetic, the baby will also develop early onset type 2 diabetes mellitus. They have a higher chances of obesity. They have higher chances of cardiometabolic. So hyperglycemia in pregnancy is the biggest challenge. We don't diagnose enough GDM patients in our country, and therefore it is a request that every pregnant woman, as soon as she enters your chamber, you should do a single step test. So principles of preventing the long-term complications to optimize pre-pregnancy care, strive for normoglycemia in pregnancy, and track both short-term and long-term complications. This is what Dr. Jaideep has just now mentioned. The guidelines have been revised by Government of India. Even the Fogsi endorses the single-step test, but I'll let you know what actually is the situation in our country. And these are the levels that we should understand. If the levels are between 140 to 90 after 75 gram glucose load, they may be patients of GDM. But if you find the levels above 200, please start them on insulin, because these are the patients who are diabetics which were missed in the pregnancy. So any values above 200, the first line of therapy would be insulin. You can add metformin along with the insulin. So the important components Dr. Jaideep has highlighted, but for the postpartum, you have to see the early detection of infections. Breastfeeding again plays a very, very important role in prevention of non-NCDs in baby and the mother, advice for pregnancy spacing, and test these pregnant women again and again. Now, there are future risk of blood sugar, so how you test it? The first test should be done after three days, that if the patient is on insulin. Otherwise, do 75 gram OGTT. Now, this times you have to do a fasting and the postprandial. Like in a pregnancy, we do 75 gram load and do it after 2 hours. But after delivery, you have to test fasting also. And 75 gram 2-hour test should be done after 6 weeks. Then you have to repeat after 6 months. And then you have to repeat after 1 year. And from there onwards, you have to investigate every year. The cutoffs, very important. Fasting more than 120, they are frank diabetics. If the values are between 100 to 125, they are impaired glucose tolerant patients. If the sugars are more than 200, they are frank diabetics. If the value is between 140 to 200, they are impaired glucose tolerant. Now, long-term measures, important to tell them about the healthy lifestyle, breastfeeding and the follow-up, as I have told, and also the lipid profile also becomes very, very important in these patients. So how you do history, physical examination, blood pressure, BMI, and definitely every year screening of these patients. So if the normal results are there after delivery, then you have to counsel regarding the breastfeeding. It is very important. Contraception, proper spacing, educate them about the risk, which we are not doing, emphasize on importance of planning next pregnancy, encourage to avoid post-delivery weight retention. Now, women with abnormal results, you have to weigh what tests you have to do, because GDM have also been associated with thyroid dysfunctions. You should not forget doing thyroid tests in these patients as well. And also what I have mentioned just now as yearly follow-up with fasting and postprandial and also cardiometabolic risk. But the challenges are many. The awareness is not there. Awareness among the patients is not there. Awareness among the doctors are not there. We need to educate our own healthcare workers. We have to change the perception of the family members as well if you really want to make in our country. Now, I would like to highlight some 3 minutes to go. What are the challenges that are there in India in the diagnosis, management, and follow-up? I was fortunate enough as a chairperson of Safe Motherhood Committee to get an opportunity to work with USAID, and we did a project in Jharkhand. We took 30 facilities, they were all private facilities, and there were 270 healthcare workers we took on board. Now, we did the pre-training survey of these facilities. The doctors were given pre-training survey, and the healthcare workers were also given the pre-training survey. And these are the healthcare workers. We made certain posters to, and we made the logbook which were given to healthcare workers to write the cases. Now, amazingly, this was the data only 50% of the doctors were aware how do you screen. That's a basic test that we had put in. They were not aware actually how to screen, and most of the doctors were doing random tests. So this is not correct. We should not do random tests in the pregnancy. Single step test using 75 gram glucose is important. Again, amazingly, it was that they had the knowledge. They were aware that the 75 gram glucose load is recommended by Government of India, but still it was not practiced. Now, awareness among the healthcare workers, again, with 75 gram was only 43%. The healthcare workers are the first point of contact with the pregnant women, and they were only 43% were aware as to what should be the test with 75 gram and what should be the cutoff. So only 35% of the healthcare workers were aware of the cutoffs of the sugar. Now, the chart that you're showing, that I'm showing here, that was the biggest challenge for us. Most of them were using glucon C or plain glucose or glucon D as a screening test resource material. Only 40% were using anhydrous 75 gram glucose. Survey facility, if the patients were positive, the records were not maintained. So it is very important for us to take the challenge, and we need to maintain the record of these patients, and you have to follow up them. Now, these are the reality bites, some of the from the doctors after the training was over. I have detected 87 GDM positive in 1 month after correctly following DIPSI guidelines. In 25 years of my practice, I could detect 5 or 6 of them. I tried to analyze my lapses after enrolling in this project. The lab did not have adequate seating space, so women were sent home after drinking glucose. So these are the small things that we need to take care when, as an obstetric healthcare providers, we are there in the community. And with this project, it was a huge success with a great change in the practices and the knowledge of Jharkhand OBGYN Society and also the doctors and the healthcare workers which were enrolled. And Safe Motherhood Committee got this appreciation from USAID. As you can see on that side, the letter was given by the country director, Dr. Sangeeta Batra, for the work done by Safe Motherhood Committee. A lot of media coverage for this project. So I end with this quote, "An ounce of prevention is worth a pound of cure." And I pay my special gratitude to Dr. Hema Devakar for always there, for helping us, mentoring us, and for supporting. And at last, I would like to thank my committee members of Safe Motherhood Committee, because this project was possible only with their support. So thank you so much once again, and let's make this world a better place. Thank you.
So thank you, Dr. Preeti, for nicely covering the subject in given time. And you have touched all the carry-home tips, how to monitor this type of patient and how to manage in any given situation. Thank you very much.
Thank you, sir.
Carry on.
Thank you, Dr. Preeti. And I would now like to invite Dr. Madhuri Patel. She will be speaking on saving the uterus, internal iliac ligation. And she's now the running Secretary General of Fogsi. She's been the Joint Secretary Fogsi 2009, Committee Member FIGO Preterm Birth, Associate Editor of JOGI, Honorary Clinical Associate, Vadia Hospital, Mumbai. And since ma'am is there, thank you, ma'am. Over to you.
Still, I would like to see the people. Thank you, Doctor, for your kind and warm words. Respected Chairperson, my seniors and juniors, very good afternoon to all of you. At the outset, I would like to thank Dr. Shanta Kumari, President Fogsi, Dr. Archana Verma, Vice President in charge of this conference, Dr. Vidhu, Dr. Venus, and Dr. Gitanjali, and entire organizing team of Ludhiana for giving me this opportunity. I will be talking saving the uterus, the role of internal iliac artery ligation. The internal iliac artery, also known as the hypogastric artery, has a prominent role throughout all phases of human life. In the uterus, it carries blood from the abdominal aorta to the placenta through the paired umbilical arteries. Shortly after birth, the segment connecting the bladder to the umbilicus is obliterated. In adult life, the internal iliac artery becomes the principal artery of pelvis and supplies pelvic viscera, pelvic wall, genitalia, buttocks, and middle side of the thigh. There is a paper, 124 papers were analyzed. In that 394 patients had undergone, internal iliac ligation in a different branches. And what they found, the obstetric and gynecology is the branch where maximum internal iliac ligations were done, that is 53.3%, and that also especially obstetrics. So the internal iliac ligation is a life-saving procedure for PPH. So PPH is a serious life-threatening obstetric complication. It has remained one of the leading cause of maternal morbidity and mortality, not only in developing world, but also in the developed countries. The woman can die, healthy woman can die due to PPH if it is not intervened within 2 hours. So this is the quickest clearer. There are incidents of 14 million women per year, 3.6% following vaginal delivery, 6.4% following cesarean section, higher with higher factors, risk factor, and 10% overall incidence is there for postpartum hemorrhage. In 2017, WHO estimated around 295,000 maternal deaths occurs per year in the world, and out of these, 35,000 maternal deaths occurs in India, that is about 12%. And out of these, 35% of the maternal deaths worldwide are occurring due to PPH, and intra contributes almost 20%. So I have been attending the maternal death surveillance and response in a Mumbai district, and I represent Fogsi. And we found in city like Mumbai also the maternal mortality is about 12%, and that is because in Mumbai we get many referrals from peripheral. We all are aware about the causes, and the atonic is the most common cause of the PPH. So if it is not treated, it can go into hypovolemic shock, DIC, renal failure, hepatic failure, and ARDS. Traditionally, all PPH are treated by either medical treatment or radical surgical treatment. But since last 2 decades, conservative surgical procedures have been successfully used in various circumstances and forms. So we have conservative surgical line of treatment as uterine and ovarian arteries ligation, that is our stepwise devascularization of the uterus, Billich suture, internal iliac artery ligation, and uterine artery embolization. So how they work? They control PPH, preserves reproductive function, and avoids the hysterectomy and its consequences. So in experiment in 1960 by Burchell, ascertained that by ligating internal iliac artery, you are converting the arterial flow into the venous flow. As a result, the stasis of the blood occurs, and therefore the clot formation occurs, and that's why the PPH gets under control. So we have indication like uterine atony, large broad ligament or lateral pelvic hematoma, multiple cervical tests, lower segment bleeding, midline perforation, and remember it is less effective in placenta accreta and not useful for uterine laceration. So the more commonly associated damage is nearby structure, and therefore whoever does this internal iliac ligation should be well versed with the surgery in the retroperitoneal space, and clinicians also should consider whether it is a time for the clinician to take internal iliac ligation or not. If it is a patient is severely morbid, it is better to carry out for the hysterectomy without wasting time and waiting for the internal iliac ligation failure to occur. So let us look at the surgical anatomy. Common iliac artery at the pelvic rim divides into external iliac artery and internal iliac artery. Internal iliac artery, after 3 centimeters, divides into anterior division and posterior division. So these are the branches which I am not going to go into detail. Internal iliac artery ligation, there are 2 methods, direct method and indirect method. So I would like to show the video over here. It's not coming. Can you start?
Technical team to kindly help.
Can you start the video? Are you doing or I will do? So let us see, it is a beautiful video. And, when you are at the cesarean section and the PPH occurs and there is a need for the internal iliac artery ligation, then the abdomen is already open. Otherwise, you have to take a quick decision of opening the doing the laparotomy, and you deliver the uterus. Is it starting? Yeah. Should I? Okay. So you have to open the peritoneum at the round ligament and, and carry this opening, towards the lateral pelvic wall. And it is very easy to trace the external iliac artery and go upwards cranially. And at the same time, you identify ureter and the common iliac artery. So you go up to common iliac artery, and when you are going, up cranially up, you have to open the sheath. And you can see now, external iliac artery over here, and you can see over there the common iliac artery. So now there are two methods I mentioned about the direct and the indirect. So directly you are going to, go below the internal iliac artery, but you have to be very careful because there are chances of, injury to the internal iliac vein, which is posterior and laterally. So this is a direct method where you are passing your mixture and will be ligating. So I'm showing you this is a direct method. Now there is another indirect method which is very, very safe. Here you are opening the sheath on the common iliac artery. And now this is the indirect method. So below the common iliac artery, you can pass the mixture, which is very safe. Feed the mixture. And remember, you have to use unabsorbable suture. Now see what happens now. Again, you pass the mixture below the external iliac artery. It is again safe. And now you just see how it sits on the internal iliac artery. So this is an indirect method where more safety is concerned there instead of going below the internal iliac artery. And then you have to suture 3 centimeters below the internal iliac artery, so you avoid the posterior division. Okay. So you have to remember certain facts about the internal iliac artery. Femoral pulsation should be felt, should be palpated before and after the internal iliac artery. Are used to help recanalization after primary object is served, but it makes no difference. Bilateral is indicated in atonic PPH, unilateral in the broad ligament hematoma, and overall success rate is about 58%. After ligation of the internal iliac artery, collateral circulation develops within 45 to 60 minutes, and that time the hemostasis is already achieved. Once internal iliac artery is performed, if bleeding continues, then you should not wait, straight proceed with the hysterectomy. And as I have already mentioned, that you have to look whether the patient can withstand the internal iliac artery and going for, hysterectomy, then you are creating more morbidity to the patient. In uterine rupture, there are many people who do internal iliac artery ligation and then proceed with the suturing, because the bleeding is more. And depending upon whether you want to do suturing or hysterectomy, depending upon the blood loss and the site of the rupture. And in an extensive vaginal laceration, suturing is performed first, and then you can suture the laceration in the vagina or the injury in the vagina. There is a paper by V.M. Joshi et al. Where they did 106 women with atonic PPH, internal iliac ligation, and then they landed 33 patients landed up with the hysterectomy. Hence, the salvage rate of the uterus was 68.8%. And it also depends the success rate is more if the time interval between the bleeding and the internal iliac ligation is less. Then among 19 women with uterine rupture who underwent internal iliac artery ligation required hysterectomy. So it gives salvage rate of 21%. So as far as uterine rupture is concerned, it is not that effective. So there are accidental ligation occurs in the external iliac artery, ureteral injury, retroperitoneal hematoma, central pelvic ischemia, breakdown of the perineal skin, and failure is associated with more morbidity. So in the systemic report reviewed by Gautama Chitagari et al., reported that ischemic complication after internal iliac artery were reported fewer in obstetric patients. Why? Compared to the other field. Why? Because the obstetric patients are younger, collaterals develops within, effectively because they are not a case of atherosclerosis, and thirdly, the estrogen levels. So to conclude, internal iliac artery is a valuable procedure in treatment of PPH and its prevention in high-risk women. Early resort to internal iliac artery is the key to prevent hysterectomy in women with uterine artery. In traumatic PPH, internal iliac artery facilitates repair or hysterectomy when indicated and prevents reactionary hemorrhage. All obstetricians should be aware about this procedure. Can play important role in achieving sustainable development goal of reducing MMR to less than 70 per 100,000 live birth by 2030, because we know the PPH is the major killer of our mother, almost 40%. So if we can learn all these techniques, we can definitely, reduce the maternal mortality. So internal iliac artery ligation saves the uterus, saves the life, makes a difference, one of the solutions for interactable PPH. I thank all of you for the patient hearing.
Thank you, Dr. Madhuri, for such a wonderful, elaborate deliberation on the internal iliac artery ligation. It's such a life-saving procedure at the time of the bleeding when there is really a huge mass in the theater and the patient is saved of the hysterectomy. So you have very nicely explained and shown the procedure of ligation, and thank you very much for this.
Thank you, madam. Thank you all, chairperson. Thank you, everybody.
Dr. Madhuri, a quick question for you. Yes. Since the patient is very serious and we know, okay, we can do this thing, but do you think for this the vascular surgeon should also be included because of the medical legal purposes?
Yes, yes. Always. It is a teamwork. And when the facilities are available, you should always do with the team. But if the facilities are not available, so as an obstetrician, we have to learn all of
Go
this.
ahead. Thank you so much.
One comment I would like to make, Dr. Madhuri, is that it is a timely intervention which is most important. We should not be wasting too much of our time in deciding when to proceed for internal iliac ligation. Before the patient goes into irreversible state of shock, we should do some intervention. So it is actually the timely intervention which is going to save life. Thank you so much for your nice presentation.
Thank you so much.
Thank you, ma'am. Thank you so much for enlightening us. And now we have with us Dr. Aruna Suman speaking on tactics of optimizing cesarean section rate. Ma'am is a professor in the Government Medical College, Jagitial, Telangana. She's the Vice President, OGSH, and Joint Secretary, Fogsi 2021-22. Over to you, ma'am.
Respected chairpersons, good evening, everyone. I thank Dr. Shanta Kumari madam, Dr. Archana Verma madam for giving me this opportunity, and I congratulate the team of organizers, Dr. Venus Bansal, Dr. Vidhu Modigil, and Dr. Geetanjali Kaur for excellent scientific program, and thank you for the hospitality. Now coming to my topic, tactics of optimizing cesarean section. The cesarean section rate
can be safely reduced by complex interventions that involve health seekers, health professionals, and health organizations, not forgetting the stakeholders or the politicians. Analyzing and modifying our practices, multifaceted strategies based on audit and detailed feedback, which is advised to improve clinical practice effectivity. And this support the assumption that the identification of barriers to change is a major key to success. The optimal cesarean section rate is unknown, but it varies between differences in the obstetric populations that are attended. Congratulations to all of us. Yes, we have achieved our maternal mortality ratio is now 103. But the birth pangs have gone up in India. The cesarean section rate is increasing a lot. Not only in India, but it is increasing worldwide, and we need to work on it. More vaginal births is the need of the hour now. Is it a myth when I say the WHO recommendation in 1985 was 10% to 15%? Can it be at the present scenario? No, it cannot be. Yes, it might be a myth. Why there is an upward trend of increase in the rate of cesarean section? Because of dramatic changes in the indications in recent years, more cesarean section is performed to benefit the fetus rather than the mother. So according to the evidence-based approaches, what can we do? So the common and important indications why we do cesarean sections is fetal distress. So less use of electronic monitoring system, especially in low-risk cases, yes, the rate can be decreased. Prolonged labor, we can use partogram. Breech presentations, if they are favorable, we can allow in breech presentations. Multiple gestations, if the first win is cephalic, definitely we can allow for vaginal delivery. And previous section, we should try for TOLAC, maternal request, a big no, and cesarean section on demand. When there is a proper indication, cesarean section can prevent maternal and neonatal morbidity and mortality. The increased rate does not mean reduced neonatal morbidity and improved maternal mortality. The trend should be towards improving the intervene. So health education for women is an essential component of antenatal care. So we have to explain regarding the vaginal birth to the family and to the mother as well as the husband. Maternal request. Why do we go for maternal request? Because of social convenience and planning, peer group pressure, tocophobia is other factor, to avoid fetal risk, to avoid maternal risk, and the obstetrician's ease. Now, what is tocophobia? This is fear of childbirth. So we can handle this by constant support, counseling, and proper pain management, maybe with epidural. Is cesarean section as safe as we think? No, it is not. 4-fold increase in maternal mortality will be there, and elective section 2.8-fold greater chance of maternal death compared to vaginal birth. But still, when we say cesarean section, we are ready. Now today, we have to sit at a round table to discuss the route of vaginal birth and target to reduce the cesarean section. We all here, especially the greatest hazard is iatrogenic prematurity and the late consequences, a dreadful placenta adherent syndrome, where if it is whatever it is, obstetricians, we should be ready to face these future intervention to the healthcare professionals. Implementation of evidence-based clinical guidelines combined with structured mandatory second opinion of cesarean section indication wherever it is feasible, like in centers with high section rates and adequate resources. So focusing on the vaginal births, we have to know the risks and benefits. So what are the contributing factors that are increasing the rate? Non-clinical factors, changes in characteristics of the population, small family norm, average maternal age, pregnancy has increased, and general shifts in work and family responsibility, multiple pregnancy, obesity, obstetrician's decision because of the time pressure, fear of litigation, suspected low birth weight, infant low birth weight, and decrease in operative work, increasing and maternal BMI, organizational, economical, and social factors. What about the clinical factors? Increased use of intrapartum fetal monitoring, induction of labor, which is improper. We had a good discussion in the morning, so we have to individual, and increase in medical disorders, decrease in VBAC, increase in elective sections, a non-medical indication where there is more number of deliveries in a center, and clinical practice guidelines, single obstetrician, nursing homes and maternity homes, breech and other malpresentations, and infertility. So first of all, the first and foremost thing is we have to prevent the primary cesarean sections. We all know the indications. Preventing the first cesarean section may be the best way to decrease the overall rate, since 80% of them will have a repeat section. Now coming to the proper intrapartum care, definitely we can decrease the cesarean rate. We have to use a simplified partograph from WHO during labor, and proper interventions or proper reading of fetal heart rate tracings. We have to remember Dr. C. Bravido, Dr. Arul Kumaran has given us this a good guideline. And a big no to medicalization of labor, as there is no evidence. Unnecessary ARM or starting oxytocin is not advised. Now, a birth companion is definitely a good factor to reduce. The birth companion is someone who will be with the laboring woman during an emotional supports, and there are many benefits of the birth companion. And we have to retrieve the lost art of operative vaginal delivery. So let us have a lot of training sessions and let us retrieve the lost art. Now, this is an important factor, definitely reduce the cesarean rates, doing a group practice. A group practice is better than a single obstetrician, which reduces the time pressure, focus on quality care, decision making, because we'll have a second opinion, and helps in medical legal cases. We should definitely encourage the TOLAC, but there should be proper monitoring. This is one of the indication for doing a cesarean section where we suspect fetal macrosomia and do a section. If there is a feasibility, definitely we have to allow for trial of labor. One of the biggest problem nowadays is maternal obesity. So pre-pregnancy counseling, maintaining proper weight, diet, exercise, everything is important. These are the extra advantages of having a vaginal delivery, especially introduction of the flora, which will have a normal introduction of the gut microbes in the fetus is more important. Our Krishna madam is sitting here. She definitely talks about the gut microbiomes. So how do we bridge the gap? There is a lack of knowledge regarding the criteria of labor management. So there are related to operative vaginal delivery. And coming to the interventions targeted to the health organizations. For a sole purpose of reducing the rate of cesarean section, a collaborative obstetrician model of care is very, very important. So this will have a focused monitoring, one-to-one basis, can reduce intrapartum cesarean section. Midwife role is very pertinent, and it can decrease the maternal mortality. And again, interventions targeted to the health organizations. For the sole purpose of reducing the unnecessary cesarean sections, the financial strategies should be properly planned. So the vaginal delivery and the cesarean section should also have a normal price. Now, The interventions that we have to target all the health professionals and organizations. Implementation of evidence-based clinical practice guidelines, auditing, cesarean section audits, and timely feedback to healthcare professionals are recommended to reduce unnecessary cesarean section. So there should be an ethical team in the hospital, an audit team consisting of 2 obstetricians, anesthetists, neonatologists, head of the institution, and a nurse also. So we have to do a proper auditing and analyze our rates of cesarean section using the Robbins classification. Every woman admitted to deliver in any facility can be classified into one of the 10 groups. And there is modified Robson's criteria group. This is the Robson's criteria. Based on the available data and using international standards, WHO concludes cesarean sections are effective in saving maternal and infant lives, but not only when they are required for medically indicated cases. So we have to perform only in medically indicated cases. What are the tips? So coming to the tips and tricks, antenatal counseling, prepare women for normal vaginal delivery, lot of education, plenty of exercises, versions for breech, stripping to avoid labor induction, midwives, birth companion, trained non-medical person is a birth companion, delays in epidural, and safe birth checklists. So definitely promote vaginal delivery. And we have to have the evidence-based role. This is our goal. So the 10, any doctor should explore social media to connect with each other, to engage, to inform, to reflect, to share, to be challenged, to be supported, to lead, to learn, and to inspire. So we have to keep in touch with each other, working towards health. And think twice before you take a cesarean section. And Surakshith Nari hai Humari Zimmedari. So we all have to take this Charak Shapat, and we have to say we will definitely think twice before we do a cesarean section. Thank you so much.
Thank you, Dr. Aruna, for the nice presentation. Any comments from the house? This is an important topic. I think we really need to decrease the incidence of cesarean sections.